So as he briefly mentioned, we're going to talk about prostate cancer awareness, screening, and then the treatment of prostate cancer as well. So to start, let's talk about what the prostate is. So that's the little organ right below the bladder here, so kind of circling it, the little walnut-shaped one. You can see there's one tube that runs through it from the bladder, so that's the urethra, that's the tube that carries pee from bladder out. And then you also see a connection here. So these objects here are the seminal vesicles. What they do is create a fluid to help carry semen and sperm out, so it's part of the ejaculatory system as well. That also meets up in the prostate. So essentially, the two main functions of the prostate are to help with urination and ejaculation because of all those connections.
Could you speak more into the microphone, please?
Yes, I can. So then what's prostate cancer? Prostate cancer is when there are abnormal malignant cells that begin to grow within the prostate itself. Now, symptoms of prostate cancer. I want to start by saying that most patients do not experience any symptoms that are signs of prostate cancer, but some things that can be symptoms include pain when urinating, an increased need to urinate, and a slow stream when urinating. However, those symptoms especially can be a sign of a benign process as well, and so they kind of overlap there. Other things include blood detected in the urine or your semen, back or pelvic pain, really like deep bone pain, and then just weakness overall. Yeah. And so prostate cancer risk factors include being a male who has a prostate. Age is really the biggest risk factor. Incidence of prostate cancer increases rapidly after the age of 50, and over 60% of new diagnoses are after the age of 65. And then African American race. So African American men are more than twice as likely to die from prostate cancer than Caucasian males. And then family history, so having a first-degree relative, a brother, father, more than doubles your risk of being diagnosed with prostate cancer. And then other things such as smoking and obesity also increase your risk. And so how common is prostate cancer actually? It is the most commonly diagnosed cancer in men in the U.S. other than skin cancer. The American Cancer Society predicts that in the year of 2023, 288,300 new cases of prostate cancer will be diagnosed, with approximately 34,700 deaths from prostate cancer itself. More men will die with prostate cancer than from it. However, it is still the second leading cause of death in American men. And overall, about 1 in 8 men will be diagnosed during their lifetime, but only 1 in 41 will die from prostate cancer. So how do we detect it? We do prostate cancer screening. Obviously, the goal of a screening program is to detect a cancer at an early stage to where it can be treated. There's two main components to screening for prostate cancer. It's going to be the DRE and PSA. So the DRE is what we call the digital rectal exam. That's where we take a finger, it goes into the rectum, we're actually able to palpate that posterior aspect of the prostate. We're really feeling for any nodules or concerning features. The PSA is a blood test, and we'll kind of touch on it here in a second. According to our AOA best practice guidelines, men ages 55 through 69 should have a shared decision-making conversation with their primary care doctor or the urologist if they're already following with one on if they should be screened. It's not recommended in men under the age of 40 or above the age of 70 or anyone with less than a 10 to 15 year life expectancy.
How strong are you? Can you open that for me?
Now, for the ages between 40 and 54, if you have high-risk features such as a first-degree relative, African-American male, you can also have a shared decision-making discussion on if you should get screened sooner in that 40 to 54 age range. So PSA, that stands for prostate-specific antigen. It is a protein that is made by the prostate and then can be released into the bloodstream. And so we utilize a blood test to tell us what your PSA amount is within your system. And you can see at the bottom here, there's a table, and the normal range increases as your age increases. And that's because a normal benign process that typically happens in males is that the prostate enlarges. And so that kind of accounts for that number. And then what are things that can cause an elevated PSA? So when we're talking to you in the clinic, we're gonna try to rule out some of these more benign factors and determine if your risk is really from cancer. And so things that can increase the PSA include an infection, such as a urinary tract infection or a prostate infection that irritates the prostate and causes it to release a bunch of PSA into your system, and therefore that blood number will be much higher. Trauma also does the same thing, so any injuries to the area, horseback riding can bump on there and increase it, long motorcycle rides, etc. And so keeping that in mind when we're talking to you. And then as I've mentioned, enlargement of the prostate itself can briefly increase or can slightly increase that number as well. And so ultimately what we're trying to figure out is if that elevation is from cancer. Okay? So you get an elevated PSA score number. What do we do next? So again, the first step is going to rule out those other causes. Did you have an infection? Did you have some trauma? And then we're going to repeat the PSA if you haven't had one recently. Make sure that that number wasn't some erroneous or outlier. Make sure it is a true number. There are some biomarkers out there that some people use kind of between there to discuss risk and moving forward. We don't do those often because often we can figure out proceeding forward with further modalities without needing those biomarkers, but you might read about them if you check that out. Next step could be a prostate MRI. So MRIs have become very sensitive to the prostate. They're able to pick up on these characteristics that tell us if you have a lesion and if that lesion is actually concerning for a clinically significant prostate cancer. So sometimes that can be used as an in-between step before proceeding to ultimately the prostate biopsy. And the biopsy is the most important part in this aspect. This is done in our office, so we can do this under local anesthetic. And so we utilize a transrectal ultrasound probe, put it into the rectum. We're actually able to visualize the whole prostate from this. We numb it up using local anesthetic, and then we take 12 cores of tissue. So we get 12 biopsies, 6 from the left side, 6 from the right side, and kind of working from front to back and in and out. So we really want to get a good sampling of your whole prostate. This is important because getting that tissue actually tells us what's going on. The pathologist is able to look at it and tells us what's going on. Now, with a prostate biopsy, there are some side effects. They're very minimal. There's a chance of infection. We give you antibiotics surrounding it. You might see some blood in your urine, stool, ejaculate. You might have some urinary symptoms just for that period of time while you're healing. And then you might have some urinary retention where you can't pee immediately after the process as well. However, you're typically able to go home and the next day there are no activity restrictions for this type of biopsy. So now we get the biopsy results. What do they mean? So you might get a negative biopsy. However, even 20% of negative biopsies have a false negative rate. And those that, we see a high PSA, clinically we're concerned for a cancer, it comes back negative, we're gonna follow you pretty closely just to make sure we didn't miss a spot there, okay? However, if you get a positive biopsy, about 40 to 45% of men with an elevated PSA will have a positive biopsy once we get to that point. And then the pathologist is gonna tell us a bunch of numbers. So they're gonna tell us some score. It's called the Gleason score, and it's based off of how abnormal those cells are and how prominent they are. They'll tell us that, and then we put that into a grade group. It's really the most important part for you guys to understand, because there's 5 grade groups, 1 to 5. 1, if your pathology is rated in the 1 group, that's the lowest risk and kind of the least aggressive. Works all the way up to 5, which is the highest risk and the most aggressive. And so we'll talk to you if you get this positive score and tell you where you kind of fall on that grade group from 1 to 5. Now, utilizing all of that information, your PSA number, and other history and risk factors, our National Comprehensive Cancer Network has this risk stratification. There's a lot of words up there, but what it is it puts you into a risk category. And basically, whatever category you fall in based off of your numbers, your features, it tells us exactly what to do next. And so it ranges from very low risk to very high risk. And based off what category you fall in, it tells us what we should talk to you about next. And so you can see very low risk, and then the intermediate groups kind of split up, but those low risk ones we can actually actively surveil, which we'll talk about here. And then the next ones might need some further imaging before we do any treatments to treat the cancer itself. So what are these treatment options? Like I mentioned, there's active surveillance. There is a localized prostate cancer treatment. However, you have to have very specific characteristics of your cancer to get this. It's called HIFU. We've just started doing this out at KU. But it can treat certain volumes, certain spots, and certain risks of prostate cancer. And then the mainstay of prostate cancer treatment is either going to be surgery or radiation. So active surveillance. If I come in you come in and I say, you have grade group 1 disease, this puts you in the very low risk category. I just told you that you had cancer, but I'm going to tell you that we're going to do nothing about it except actively surveil it. And so evidence has shown that a lot of these very low risk cancers, they don't become clinically significant. And so evidence has let us know that we don't necessarily have to proceed with these big treatments that have risks to them, but we can actively surveil with PSAs, the digital rectal exams, and then if anything, bumps up or becomes more concerning, then we just do some more imaging or possibly another biopsy to see if anything became more clinically significant. Okay. And then really the next two treatments I'm going to talk about are going to be either surgery or radiation. And so surgery is called a radical prostatectomy. Ultimately, that means that we're taking out the whole prostate. When we do this, this is often approached robotically. And so it's really small incisions in the abdomen. We put our tools in and then it's all done at the robot. We go in and we remove the prostate. So you can see here, that first step, we're removing the prostate and then we reconnect the bladder to the tube you pee out of, that urethra, okay? We also take the lymph nodes that are down in your pelvis. That's the first place that prostate cancer is gonna spread if it's gonna go anywhere, because that's what drains the prostate. So by taking that out, we not only get better staging, so we can treat you better, but then we know actually where things are at. Recovery after this kind of surgery, you typically stay 1 to 2 nights in the hospital. You will have a catheter in place for about 7 to 10 days. That's to allow that reconnection to really heal. There is some lifting restrictions. We want those incisions to heal well without having hernias, so no lifting greater than 10 pounds for about 6 weeks, 4 to 6 weeks. You do have upfront incontinence or urine leakage, and that's as well as some erectile dysfunction. We'll kind of talk about that a little bit further. So for the incontinence, you can see in this first picture here, when you have the prostate in, you have 2 sphincters. The sphincters are what help squeeze and hold that urine in before you have to go. When we take the prostate out, we actually lose one of those sphincters as well as mess with some of the nerves. And so you are going to have some incontinence, have to kind of retrain after the surgery. It's important to know that about 90% of the males who undergo this, they go back to about baseline in about 3 months. And then if you are in that 10% or so that has persistent incontinence or leakage, there are further treatment options for that. Now, erectile dysfunction, this happens because the prostate has some nerves around it. So on each side of the prostate, you have this bundle of nerves, and those nerves help with erectile function. So when we go in and take out the prostate, if you have kind of a right-sided prostate cancer that is really close to the edge, we're gonna have to take that bundle of nerves as well. We often try to leave at least half if we're able to, based off of your pathology and imaging, to allow for better treatment options afterwards. And so afterwards, you kind of have to rehab things, allow those nerves to kind of figure itself back out after we just did that big surgery. But there are, again, treatment options afterwards. So medications, injections, and even prostheses. On the other side of things, there is radiation therapy. The radiation oncology doctors will be the ones who head this part up. This uses high energy beams to kill that cancer, and it's aimed at the prostate and kind of that pelvic area. Or there is a different type of radiation therapy that has radioactive pellets placed into the prostate. With radiation, it does affect healthy tissue that is within that path. Usually it involves about 5 days a week 5 days a week for over several weeks, with about just under an hour session. Side effects of this are kind of upfront. And so upfront, you kind of get some dysuria, so painful urinations, blood in the urine. You will have erectile dysfunction while you're undergoing it. However, afterwards, for a period of time, usually that comes back to about normal. And then you see some more delayed effects. So the erectile dysfunction, the leakage can happen further down the line at about 10 years, just because those tissues become so friable after the radiation therapy. And then another treatment that typically goes along with the radiation therapy is called androgen deprivation therapy. People hear it called hormone therapy. Essentially this, the goal of this treatment is to reduce the level of the male hormones called androgens in the body to really stop them from fueling any prostate cancer that's in the body. So really, when we're in the clinic and you've been diagnosed with prostate cancer, we're gonna have this risk-based discussion on what's best for you. Should I go the surgery route or should I go the radiation route? And there are pros and cons to each. We've pretty much touched on all of those pros and cons. You have to decide what's best for you at your stage in life when you get this if you get this diagnosis. However, it is good to know that the pathway of starting with surgery and then if you recur and get radiation, or starting with radiation if you recur getting surgery, they're equally effective treatments with equal curative rates. Now you've been treated, so you chose a treatment, you've been treated, what's that follow-up entail? So follow-up is always specific to what the results were of the surgery or the radiation or your PSA numbers, but they often involve monitoring your PSA for a period of time, possibly DREs if you still have a prostate, and any imaging as clinically indicated. This often occurs for at least 5 years, making sure that your PSA doesn't do anything in that time period. And we know that if it doesn't do anything concerning after that 5-year period, we can often let you go. So what happens if it recurs? Well, we'll see a PSA jump. So if we take out your prostate with surgery, there should be no prostate tissue left to create a PSA. So your PSA should become undetectable or essentially zero. So if we start to see that PSA creeping up after we took your prostate out, we're gonna be a little concerned for a recurrence. Once we hit the PSA of 0.1, we consider that a recurrence and we start talking about further treatments. Now, if you just had surgery, your further treatment is gonna be radiation. It's gonna be the same thing that we talked about previously, that external beam radiation to the prostate bed and any lymph nodes or tissue that's left over. We would get imaging most often between that to make sure there hasn't been something that's spread elsewhere. And then if you had radiation first, we have the discussion of salvage prostatectomy. What that means is a surgery to remove the prostate after the radiation. Again, that's gonna have to be a risk-based discussion if you're healthy enough and if we feel like that's gonna help you. That can be a little bit trickier because we just radiated those tissues and they're a little more friable at that point. There are some other systemic therapies, so the hormone therapy and other things that can help as well at this point. And then if you are diagnosed with metastatic disease, ultimately this is any disease that's far outside the prostate. The mainstay is systemic therapy, so something that's gonna treat the whole system. Hormone therapy, again, is involved in this, and then this can be further combined with other additional hormone agents, chemotherapy, immunotherapy. We would have a medical oncologist typically take over at this point and help decide what the next best treatment is for you. And then, so to support any prostate cancer research or patients, there's the American Cancer Society of Missouri and the Prostate Cancer Foundation. And then September is Prostate Cancer Awareness Month, which is why this discussion was a good one, and I'm glad that you were all able to make it. Here's the references, and thank you all for coming today.
What are contributing factors in being susceptible to that?
Yeah, so the risk factors are gonna be, age is the biggest one, and so as you age, the incidence of it increases quite a bit. Family history, so having a first-degree relative that has prostate cancer is going to increase that risk or susceptibility of being diagnosed. So say a father or brother, that almost doubles your chance of being diagnosed with prostate cancer. being African American male, and then smoking and obesity as well.
Yeah, I saw those at the first, but are there other things, you know, like diet?
There has been some conversation about smoked foods can increase risk, but otherwise not really.
Did I see something about PSA over 70 is not necessarily recommended?
Correct. And so per our guidelines, we typically, if you've had a normal PSA or nothing concerning up to the age of 70, we recommend to stop screening. Now, if you're in very good health and you've had some maybe teetering PSAs, we would have a risk-based discussion on continuing.
But if you've had a low PSA up to 70, then you don't really need it.
Per our guidelines, yes.
Could you explain that? Why is there 70 to cut off?
Yeah, so we know that if we've watched you, again, so age is one of the biggest risk factors. So at the age of 50 or 55, we typically start screening for this. And we know that if we've been screening you for 15 years and your PSA has not been concerning, the chance of your PSA randomly becoming concerning at 70 or shortly after, and concerning in enough in a way that we're gonna find a clinically significant prostate cancer that you'll ultimately die from, is so incredibly low, right? And so it takes prostate cancer a long time to develop, and most prostate cancers develop very slowly and remain indolent. And so we know that if we haven't found anything by 70, you probably aren't gonna have one that comes about that would need treated.
I've got prostate cancer, and it was, discovered with elevated PSA. He bought my urologist biopsied me, couldn't find anything. So he had to go to an MRI. I'll never do that again. I guess they messed up my chromosomes. But it was found with the MRI. And, we're just watching the PSA count every 3 months, and then every 6 months. Running about 15. But then I had a workmate that said he had his prostate taken out at 7. So.
Yeah, so the biggest thing when having that discussion and deciding what to do next is what the pathology actually comes back as. And so if it comes back, you know, I had those grade groups. If it comes back as a lower grade group, we'll have that discussion. Now, having a higher PSA does bump your risk up, but I'm not sure your history of PSAs and kind of the further discussion that was had prior to that to make the decision to
He doesn't
proceed
seem to
with.
be too concerned about it, so I guess I'm not either. It's been a couple of years now.
Yeah, I think if the decision was made to go with active surveillance and you've been okay on that for a couple of years, it sounds like that's a great plan for you.
But 15 is pretty high though, isn't it?
It is high.
I've never had any trouble with my prostate, and my PSA's been low, but I've been dealing with bladder cancer for 5 years. And right now I'm in remission. Once you've had cancer, you're never cancer free, you're active remission. But, they use chemo every year, and they put it right in the bladder. And, then they scope me a month afterwards, and I'm still, in remission. Should there be any worry about maybe going into the prostate in the future?
You mean like invasion of the bladder cancer into the prostate, or a separate prostate cancer?
Or, well, is there in danger of it going into the prostate?
I think that if they're doing those surveillance cystoscopies, the camera in the bladder, and not finding anything, it would be rare that it would already be in your into your prostate if it's not being seen in the bladder.
What?
Well, I see the doctor on a regular basis about it.
Yeah, and that's good. That's going to be the best thing to stop it from becoming progressing. Go ahead.
What if a person has varicocele and you take finasteride, Flomax, used to ride horses?
Yeah, so the
Would that lead to cancer ever? Varicocele?
No, the varicocele should not. That is around a different area of the genitourinary system. In terms of finasteride and Flomax, those were probably prescribed to you for some urinary tract symptoms. It obviously takes effect on the prostate. Now with finasteride, it can actually decrease your PSA number, And so you always have to make sure your urologist knows that you're on finasteride, so they can account for that when they're looking at your PSA, because it can cause it to look falsely low. And so we need to know that so we can account for that and kind of calculate the appropriate PSA for you. But that itself should not induce a prostate cancer.
What causes prostate to grow and you don't have cancer?
Yeah, so that's a benign process. So if you've ever heard BPH or benign prostatic hyperplasia, it's just a normal process as you age. And so just that tissue just enlarges or it becomes hyperplastic. It's totally benign. It's completely separate from prostate cancer. As we saw in kind of that first picture, that tube that you pee through goes through the prostate. And so that's why you get those urinary symptoms. If your prostate starts to grow, because it starts to kind of close in on that tube there and cause some of those issues with urination, but completely separate from prostate cancer process.
Does that have anything to do with sexual activity?
The other one, the benign process, it shouldn't necessarily. It shouldn't cause any issues with sexual activity, erectile function.
I mean, a lack or excess?
It shouldn't cause issues either way.
There you go, guys.
Yeah.
So, if you are not an MRI candidate, what would be first of all, what's the number that you need to be worried about?
So it's age related. Let's see if I can. So it's all age related, right? And so based off your age, it'll calculate and tell you if it's high or not. And so here's kind of the age number here. And so based off your age, oh, there we go. So it's age related, and so it'll kind of ding if it's high. So anything over these numbers, we have that discussion. Now, if it's high and we're concerned, if it's much higher than this and we're concerned, then we're gonna go straight for a biopsy. If you have big risk factors, if I feel a nodule on your digital rectal exam, we're gonna proceed with the biopsy because we have a very high suspicion for it. Now, if it's slightly elevated, you don't have a ton of risk factors, that MRI can really help us to see if there's any lesions that are in there to target on that biopsy. So it's kind of a good in-between stage.
Yeah, but my husband has too much hardware to be an MRI candidate.
So then we would ultimately just proceed with the biopsy and do the biopsy there.
Thank you.
Yeah.
Excuse me. Is there any benefit for patients who are already diagnosed with metastatic prostate cancer? Is there any benefit for them to go see a urologist, or should they go to an oncologist first, a cancer doctor first, and have them send them to a urologist?
I think ultimately they're going to have to see an oncologist. I think it's always good to be connected with the urologist due to a lot of the urologic side effects that happen from treatments. Depending on the metastasis, if there's just like one other spot, they can get kind of radiation to both localized areas and have those side effects. So often we have them connect. We like to do a lot of our ADT or the hormone therapy ourselves as well, and so we get involved on that side.
In terms of the diagnostic side, the urologist would have to do the
Prostate.
biopsy and things like that. So,
Yeah.
I think start with the urologist, and as you pick an oncologist, not all medical oncologists treat prostate cancer regularly. In fact, more urologists probably treat metastatic prostate cancer than oncologists do. So it just depends on how comfortable inside your urologist is. Some of us will refer out, some of us will do everything until they basically make cancer essentially.
Well, in the service, they always did the rectal exams, and, I didn't even know about this PSA thing till way later, and, but why don't they do the rectal exam? It seems like a pretty quick, back in the service, it was quick.
Yeah, and so I say often in the urology clinic, you'll get a digital rectal exam, the prostate exam, but it has been shown to have low sensitivity. So not everyone feels a nodule if there's one there, or they over calculate a nodule, etc. The more we do them though, so urologists do these quite often, and so we have a better idea of what we're feeling. We don't feel all of the prostate either. We're really only feeling that posterior aspect, and if you have an enlarged prostate, we're really only feeling that bottom corner. So our guidelines say that you can or can't do them. We as urologists will almost always do them.
just wanna thank everybody for coming out. On your tables, you'll find some flyers here for the health fair. Just a reminder, we have that coming up soon. It'll be the 14th. It'll be at the hospital as well as 5 of the other outlying clinics, which are listed on those flyers. Also, we will be having another lunch and learn coming up in a few months, so watch